the best of the week on Relevant Radio.
My guest today is Dr. John D. Camillo. He holds a doctorate in bioethics. He's the president of the National Catholic Bioethics Center. Let's start by looking at the concern regarding determination of death today, and maybe even just by discussing what a coma is, and maybe a persistent coma versus when we're starting to walk into the direction of questioning whether or not this person might be brain dead.
Great. Well, thank you so much, Timmerie. It's a pleasure to be back on your show. I will say, maybe to start out here, the question of coma, of course, is a question of whether we're talking about a question of neurological injury, essentially, in some form or another, whether the person is able to be aroused and responsive. This is an area where questions can begin to arise. Typically, if somebody's had some sort of neurological injury, there may be this tendency to try to understand how serious that injury is, and then whether it's to the point where it's satisfied what is currently referred to as brain death, or the neurological criterion for determining death.
So I think just starting out, it's important. There can be comas that are induced by physicians that can even be prolonged to allow for healing, that don't necessarily mean this is severe neurological injury. Maybe you can even give a couple examples that you've seen to help us better understand.
Sure. Yeah. And again, technically a coma is unarousable unresponsiveness. And so, it could be a number of situations that lead to that. There are other kinds of neurological injury, like locked-in syndrome, for example, where a person's not able to communicate. They may be inwardly aware, but they're not able to communicate to those outside that they are, so they are unresponsive to all intents and purposes from the outsider's perspective. So there can be a range of different forms of neurological injury or coma where the person is essentially unresponsive, but their heart is beating. They still have all the other signs of life going on throughout the body, but there's an unresponsiveness at the level of consciousness.
Now, discuss where some of the technologies play a part with our medical advancements, because you have where there's the brain function and also how that plays out, and maybe the body is still circulating oxygen well, and there's good electrolyte balance. Can you discuss a little bit of that side?
Yeah, sure. So basically, the body is able to, so the heart may be beating, there may still be circulation in that sense of the blood throughout the body. The person is not able to respond to inputs because of a brain injury of some sort. But there are different parts of the nervous system. You have the upper brain, you have the lower brain, or it's called the brain stem, which is tied to the functioning of a number of things like respiration, for example. The breathing drive is tied to the brain stem, and that may be still continuing to function perfectly well in cases of someone who's in a coma. And so they would be continuing to spontaneously breathe or otherwise, if they still have some of those nerve centers in the brain stem that are functional. The question of technology and sort of this line that comes in, or questions around what might be technology blurring, and this ties into some of the history of brain death, is where we get into the ventilator. So many times it could be the case that the patient needs ventilator support to continue breathing, and it's either a partial ventilator support or they become fully ventilator dependent, to where it seems that they're really not breathing on their own. And then this actually ultimately drives back to this question around brain death. What even is brain death? How is it defined legally, medically, and otherwise? But basically, one of the current standards or tests for brain death that goes all the way back to when it was first introduced as a concept in 1968 is something called the apnea test. There are 3 prongs to testing for brain death, or diagnosing the condition referred to as brain death. And those are the coma, the lack of reflexes, and a lack of breathing drive, or apnea. And so the apnea test is basically when, if you have a patient who is appears to be ventilator dependent, unable to breathe on their own, but essentially you've got this machine that's expanding the chest cavity so that they can have air intake in and out. Respiration, of course, is something that still continues to happen on the cellular level within the lungs, what we call respiration, but the breathing, which comes with the diaphragm movement, is what the ventilator machine is doing. And so that lack of breathing drive, basically what they do is they shut off the ventilator and they see, hey, does this person start to take a breath spontaneously or not? And that third test is supposed to tell us whether the brainstem is still functioning, because if they can't or they don't start to try to breathe on their own when that's shut off, then that's taken as a sign that the brain stem is no longer functioning.
Now, there's been an ongoing push by the Uniform Commission to revise that Universal Determination of Death Act that is currently in place. Maybe before we go there, it would be important to discuss, where does the current determination of death, brain death, line up with Catholic teaching on this? And what's important when discussing this?
Sure, that is actually a huge question with a lot of aspects to it right now. So there's brain death as a long history going back to 1968. The Catholic Church, I guess the most important thing to state, first of all, is that the Church has always been clear that her role is not to pronounce on the science as such, but rather to assess the anthropology, in other words, the understanding of the human person, and whether the information that we have from medical science is in alignment with a sound anthropology. So the concept of brain death is something that was proposed back in the late 60s. As I mentioned, it's gone through decades of controversy. 1981 was the time when it was actually adopted legally. The UDDA, or Uniform Determination of Death Act, that you mentioned, was put forth. That's when the President's Commission for Bioethics in 1981 proposed a rationale for how and why brain death is even something that might be considered valid, because of course it was a whole new way of understanding death when it was first introduced. And the Church herself began to grapple with this new approach to brain death, to understanding death, around that time as well. So 1981, you had the Pontifical Council Cor Unum that put out a document basically saying, hey, this is a new understanding that seems like it could be a legitimate understanding of determining death moving forward. And then you had a series of reflections over the decades that followed. Ultimately, 1995, you have the Charter for Healthcare Workers, in which we had some guidance from the Vatican saying that healthcare workers could use the neurological criteria as a valid basis for determining death in particular cases. And then you had John Paul II in the year 2000 say that it appears that the brain death criteria are consistent with a sound anthropology. However, we don't have any further statements after, let's say, 2006, where there was a Pontifical Academy for Sciences that put out its affirmation of the legitimacy of the neurological criterion. And after that time, we haven't had much further comment from church authorities on the particulars of brain death. So we have
20 years later.
20 years later, exactly, and a lot of things on the actual practice of brain death that have become more evident, more ongoing discussion in the medical literature on the concept of brain death and the practice of brain death, and quite a number of cases that have also made it to public attention in the past 10 years, I would say, 10 to 15 years. With Jahai McMath in 2013, you had a case of Aiden Hailu in 2015 in Nevada. So there are a number of cases that have become high profile cases that lead us to seriously question and wonder about whether either is the concept valid, or is the concept valid but the practice is inadequate to meet the concept of brain death. And so we don't have, as I said, recent authoritative guidance from the Church that would say one way or the other. And at the end of the day, what we have is essentially the Church, as in many areas, saying, hey, we're here to make sure that the understanding of the human person is adequate, But we're not here to tell you what the best testing that needs to be done to determine death specifically actually is. And so the church has to work with philosophers, medical scientists, theologians to make sure that our understanding of the human person as body and soul is adequately reflected and then respected in whatever medical criteria are being used for determining death. And perhaps a quick way to wrap up this is actually to point out 2025, November, the U.S. Conference of Catholic Bishops put out an updated ethical and religious directives for Catholic healthcare services, which is a document with a 100-year tradition. And in the 7th edition, one of the updates was actually to directive number 64, which involved determination of death. And they strengthened the language in there from what it used to be to where now they say very clearly the determination of death should be in accordance with well-founded medical criteria that establish with moral certitude that death has occurred, which represented a strengthening of language. That language of moral certitude was not included in the directives before, although it's certainly a part of the longer Catholic tradition in this area.
And I remember when Pope St. John Paul II, in the last handful of years of his pontificate, really challenged the medical community and the latest technology. Let's have good testing for this. Like, let's make sure we have adequate testing. And as you were talking about, it approaches it from the anthropological perspective, but is the testing adequate for the determination? Now, part of the reason why I think this conversation is very relevant, there's this ongoing push to change what the determination of death is that really would not fit with a moral approach to death. And I think in a culture right now, Dr. D. Camillo, and if you're just joining me, my guest today is Dr. John D. Camillo. He is the president of the National Catholic Bioethics Center, holding a doctorate in bioethics. One of the big concerns is this culture of death, as Pope St. John Paul II spoke of, that we have very predominantly in medicine today surrounding end-of-life circumstances or simply any type of suffering, where you have physician-assisted suicide legal, where you have euthanasia being practiced, although not allowed, just to distinguish between the two. Physician-assisted suicide is just as it says, where the patient is cooperating with the physician. Euthanasia would be where another person, whether it's a family member or a physician, is choosing to end this person's life based on certain criteria that they find to be eligible, or maybe is eligible in a particular country. But with that as the backdrop, there's a lot of concern, and I am repeatedly hearing it brought up actually quite frequently by people, that the determination of death and the practice of it are not matching up in many circumstances. Could you speak to that?
Absolutely, yes. So apart from what we could say is the whole concept of brain death, the actual determination in practice. So let's start from this premise. I mean, we have a definition under the law right now set out by that Uniform Determination of Death Act, which says that you can determine death by the irreversible cessation of circulatory and respiratory function, number one, or number two, irreversible cessation of all function of the entire brain. So that's the de facto legal situation we're operating under and have been for several decades. The practice then is the question of, wait a minute, now what tests do we do to determine whether irreversible cessation of all function of the entire brain has in fact occurred? And that is where, we at the NCBC, particularly in recent years, have been alerted to some of these changes that you're mentioning, the Uniform Law Commission and the questions of efforts to update the UDDA, where essentially what's been happening is that they're saying, hey, the reality on the ground is that the tests that are being done for brain death are not actually telling us whether there's complete and irreversible cessation of all function of the entire brain, because there are more and more cases of people who meet those criteria for brain death set by the American Academy of Neurology. They meet those criteria, and yet they continue to live. They regain consciousness at a certain point, or they show recovery after extended periods, and whatever the case may be. And yet they met all the tests that the American Academy of Neurology says were needed to declare them brain dead. And again, whether or not that legal definition is adequate, which is a question in itself, the point is that the practice on the ground of the medical testing is not matching that legal standard. And that was actually the case of Aiden Hailu that I mentioned, where this exact thing happened.
Share the story.
Yes, the young woman who was on a ventilator, intensive care, declared brain dead, and the father contested the determination. It went to court, and ultimately, he actually was successful in challenging the brain death determination on the grounds that the court ruled, well, even though they met all of the standards of the American Academy of Neurology, the court said that doesn't tell us that this is complete and irreversible cessation of all function of the entire brain. Even though you've met all these medical tests that the standards call for. So basically that was a huge scare, in a sense, for those who were, confident in the current standards and practice standards and testing, basically saying, well, we need to do something about this. And so the proposal was, hey, why don't we change the law, since this case, among others, right, has shown that our medical testing is not sufficient to meet the legal standard. Let's change the legal standard to match our medical testing. And that's where the NCBC back in 2024, we actually put out a statement, drawing attention to all this, because, the UDDA, the Uniform Law Commission, tried to do this. They tried to update the UDDA to match the medical testing that's currently happening. But they failed. It was tabled. The whole effort was tabled, essentially. And then the American Academy of Neurology put out new guidelines right after that in October of 2023 that essentially enshrined even further in their own guidelines. They sort of doubled down on what their standards have long been, which they knew to be inconsistent with the law based on some of these test cases. And so we said, this is clearly a problem, right? We put out a statement in April of 2024 at the NCBC saying, hey, there's clearly a disconnect now that's been acknowledged on a big level between the medical practice and the legal standard. And I should just quickly note, especially for this audience, right, that legal standard, complete and irreversible cessation of all function of the entire brain, is what we refer to as whole brain death. And that is the only potential iteration of the concept of brain death that John Paul II and the Catholic Church have said might be consistent with sound anthropology. So in other words, when we say, hey, we're trying to change the law now to match the practice, that's also effectively an admission that what the church has said might be legitimate here and can be used in practice, the whole brain death standard, now has to be changed to something that's less than that. In other words, a partial brain death standard, where we're actually allowing for continued function of the brain. I think that's an important thing to point out as well here, is that, well, what does this all mean? I mean, in effect, the AAN is saying it's actually okay for people with continuing brain function to be declared brain dead. Maybe that's like a, kind of a key practical takeaway here, is like
because that's what they're practicing. That's what they've been practicing for decades, and the law does not match the practice in the hospitals. And I think, we're just walking through this. We're 20 minutes into walking through the determination of brain death, and it's very nuanced, but this is nuanced from a Catholic perspective, and then what the hospitals are actually exercising that does not actually qualify for whole brain death and what the church allows.
Right, exactly. And so now I do need to be, very clear here. I mean, especially for us at the NCBC, the National Catholic Bioethics Center, a key part of what we do is advancing these conversations and making sure we're bringing together the key stakeholders. There are many faithful Catholics who take different approaches and have different understandings of the validity of the whole concept of brain death and the adequacy of the actual practice of brain death. And so in our pages, we have a quarterly, we have an Ethics and Medics, that's a monthly periodical, where we have authors faithful to the magisterium writing and publishing on these subjects. And we called together a symposium in February of last year, 2025, of Catholic healthcare ethicists and medical doctors, nurses, other stakeholders, professors from universities who are engaged with this, philosophers, theologians, and we essentially, made sure that we addressed a number of topics in this whole area of brain death, from the medical details to the philosophical foundations, to the implications for nurses, as opposed, the question of informed consent, and all these other pieces to the puzzle, because we think it's very important that, while it's clear something is going on here that is that needs to be addressed, and it needs to be done in an ethically robust manner, we need to get to some clarity and a unified path forward. And that means bringing together people who may also be of different opinions here to work our way through the critical issues and bring clarity to these. And among other things that are worth mentioning, I guess I would say, we had this symposium, again, even of people of different viewpoints who came together, and there were a couple of key takeaways, and one of them was that well over 2/3, it was close to 3/4 of all the attendees in our symposium said, hey, given everything we're seeing here, given the recent changes in awareness on the legal and the medical side, and new literature and so forth, we actually think there's needs to be conscience protections for people to be able to say, yes, I'm not convinced that these standards are adequate. And so that's a key and important takeaway, I think, for everyone also in the audience to understand. And back to your initial case, right? If there's a question or a concern around brain death testing, that should be validated. You should have the ability to say, no, I don't want this done. And in fact, among other things, you should be able to give informed consent, basic bioethical principle, to the testing itself. And that was the other item that many of the participants agreed on, is that informed consent should be required for brain death testing. So it should be simple for you to say, well, no, I don't consent to this, or if you want to do this testing to me, you've got to make sure you explain it all to me and I give you that go ahead. And if I don't, you can't do it. But this is actually one of those same critical points of concern, is that the American Academy of Neurology, in their latest guidance and in a new position statement in 2025, they said, we don't think you need informed consent. And they're kind of pushing in the direction of nobody should be required to, we shouldn't be required to get informed consent for brain death testing. Right. And that's a big ethical issue.
And just to be clear there, if a person is in a coma and they are not able to give that consent, you would appeal to if they have advanced directives, or maybe they have someone who is in charge of their medical care, hopefully, or the first of kin that is. But there are whole other elements of, well, was this person religious? What do they believe? And so many people today, and I'm seeing this happen, are having to fight the hospital saying this person is a church-going individual, this is what the church believes, and they're quickly having to bring letters to the hospital to say, you can't just go and do this test against our will, you can't determine this. And it's turning to a mess. And I think part of the reason why this is also relevant and why I want to walk into this was, one, we never know when we may face this. But two, I think this is of particular interest today with this push to change the determination of the standard of brain death illegally, when already the practice in the hospitals does not meet the legal whole brain standard that the church does understand. The concern is we've had this increase in organ harvesting. There's a major concern with living organ harvesting. There's also the concern that many people, as you've discussed, are recovering from what would be the new determination of brain death, and they could actually recover from their illnesses.
That was the Best of the Week on Relevant Radio. The best way to listen to the Best of the Week is on the Relevant Radio app, free and always free. Download and share the #1 free Catholic app today in the App Store.